So after this cervical spine model and this facial model for the Bell palsy or whatever the treatment we want to give for the face, so that model is suitable for that activity. But now after that, we have a very heavy hand of Bahubali. That is also very important to see that how the muscle are attached with each other. It means that if I want to treat the joints, so after learning about the joints, it is important to understand about the muscles also, because we are we are going to treat the upper quadrant. So after we have treated the cervical spine, now our role start with the shoulder, where we see that in this, you can see this is the clavicle, which is coming in front. And after that, this is the spine of scapula. And this is scapula, you can see it. And with this attachment of, in this first, the deltoid, this is the big muscle and the long lever muscle, deltoid. If I will remove it, tightly packed, yes, it has come out. After this deltoid, you can see it, this is humerus, and in this we can see in the rotator cuff muscle, which is in the back, in the downside there is a subscapularis, this is, and in this posterior side you can see supraspinatus, which we use for the shoulder abduction. And after that, this is the infraspinatus and the teres minor, which normally we see that that all attachment of their internal rotation, sorry, external rotation. And after that, there is a, sorry, teres major, after the teres minor. And here the attachment of latissimus dorsi also, and the nerve supply to the subscapularis. This is attachment, and this is the pectoralis, and this is the coracoid process. And this is, after that, there are the muscles. Yes, this is biceps muscles. Sorry, bicep muscles, long head of bicep. This is going in the humerus. This is the short head towards the coracoid process. And if I will remove this bicep muscle, this is after that brachialis, you can see it. This is all the flexor muscles of arm. And there are the nerves also, the median nerve and the ulnar nerve in the lateral side. And this is the radial artery also coming. And after, in this posterior side, we are having a triceps, the long head of tricep, lateral head of tricep, long head, and this is the middle head of the tricep. This is also inserting in the scapula. So this is, you can see here, this is the radial nerve also coming out, and it is going into the brachioradialis. And here is the, you can see this is olecranon process. And you can see medially there is a medial epicondyle, lateral epicondyle. So whenever we going to treat the elbow, we know that how we palpate these bony landmarks with the medial epicondyle, lateral epicondyle, olecranon. So we palpate it. And after that, we see that in the forearm, the flexor group of muscles, or these are the extensors group of muscle. And we see that in this also, I will remove. So these are the flexors muscle, where the flexors carpi ulnaris is coming, and there is a flexor carpi radialis and superficial profundus. And this is, here also there is a common extensor tendon, or here the common flexor tendon also, because we, whenever we treat the patient for medial and lateral epicondylgia, we see that these tendons, the tendinitis, or there is a inflammation in these tendons, cause the very important role. And there is a this oblique muscle, that is the pronator, for the pronator, the pronation, the activity of the wrist and the forearm. And here there is a supinator muscle that is coming here from the extensor group, because it is for the extension, supination and extension. And this is pronation with the flexion. And these are the muscles which are going in the hand. You can see it for the hypothenor, because we are going to learn about the dequerent tenosynovitis. So the muscles which are the extensor pollicis longus and the abductor pollicis longus, that place there is a snuff box. So, or there is a radial head, so radial deviation with that. And also there is the distal hand of radius also, and the distal hand of ulna also, and all the muscles, the lumbricals, and as well as all the muscles going towards the carpal bones are inside here. And as well as we can see that in the fingers also there's a ligaments, the lateral and medial collateral ligament, if the patient is having a trigger finger, or the fingers in there is a because of rheumatoid arthritis, so we can mobilize these collateral ligament also. And in this back you can see that expansions, extensor expansion here. So this is the dorsal side, palmar side, and all the digiti minimi and the extensor digitorum, extensor digiti minimi. These are all the muscles that is going in the our hand. So these muscles also play a very major role when we treat the patient with the wrist and hand problems. Sometimes there is a trigger finger, so we treat if there is a dequerent, or if there is a, yes, there is a flexor retinaculum, which we treat the patient for the carpal tunnel syndrome. So we release this flexor retinaculum, and that time we give the glide, and the hand is in the neural position. So that is also the way. And there is a extensor retinaculum also. So how we can give release to these retinaculum also for these muscles and the nerve supply, because we know that in the medial side there is a radial nerve is coming, and there is a ulnar nerve, and for the median side, the medial, there is a median nerve, because we know that for the extension, the full extension or hyperextension, we use the median nerve. And for the lateral side, if the patient is having a problem with the lateral side, so we check with the ulnar nerve, because of the course of nerve which is coming with the flexor carpi ulnaris, or with the flexor extensor tendon. So there we do the tapping, and then we check about the ulnar nerve, or for the medial side, or here we check with the radial nerve. So this is the model. With that, all the muscles for flexor group and the extensor group, biceps and the triceps. And after that, there is a flexor group where all the muscle related to the flexion activity, or extensor group where the supply with the radial nerve. So this is the way we can easily see all about these muscles from the scapula to shoulder, the GH joint also, and with the activity of all the muscle, how the hand movement is coming, abduction and the flexion, extension. So we can add with this muscle. So our role for AMNMT, it is very important, because we are as well as the articular, myofascial and neural. So it is important to understand all the structure, so that we can treat our patient simultaneously. If their primary function is the neural, and it will affect the myofascial, because we know that extraneural and intraneural dysfunction related to nerve, because if they are there is a dysfunction related to muscle, so we have to treat the nerve according to that. We know that the nerve is in it's not getting their gliding completely. So if we activate the muscle, so the nerve will get the place for the proper gliding on their nerve bed also. Or if there is a deep structure articular, the joints are either hypermobile, hypomobiles, or they are the ligaments laxity in the joints. So that will also pull the nerve. So according to that, we can understand that nerve can influence the deeper structure, that is joint also, or the ligaments also, or the capsule, and the open dysfunction where the muscles plays a role. So the nerve can influence the muscle also. So activating the muscle, gliding the nerve, and keep the joint in that position, in that the nerve is not getting the loading, then it is articular, myofascial and the neural combination of our treatment as a AMNMT, that we will further we will see in our PowerPoint presentation. Thank you. Yes, sir.